So we'll just briefly go through how to manage phakic intraocular lens complications after the laser vision correction complications. So now, as I had mentioned earlier, counseling, measurement, and ruling out unstable refraction are very important. Now, if you, when you're doing the procedure, it's important that the intraocular lens be injected very slowly, because even after injecting a majority of the lens, in case you find that the lens is flipped, there is always a possibility that you can slowly twist the cartridge and make sure that the lens comes out the right side out. So it's very important that you inject the lens slowly. You shoot the lens in, that's not possible. But even when 5/6 of the lens is out of the cartridge, there is still a possibility that you can turn in case of a flipped intraocular, phakic intraocular lens. Now, sometimes a pupil distortion might indicate that the lens you have placed has one of the haptics lying outside, and you just need to go back in and, you know, tuck it in before you complete the surgery, and then wash the viscoelastics out. But in case you have a very well dilated pupil, sometimes you may not be able to realize that the haptics are out because the pupil looks pretty regular over here. And that's when you need a very careful eye. You need to tuck the haptics back inside before you exit. So in a large undilated pupil, you have to make sure that the transparent haptics are in the right position. Now, iris disturbances, especially when irrigation is done either by manual or by an automated IA, it has to be made sure that there is always a good flow from both above and below the ICL out through the side port. So for this, if you have an undilated pupil, it's very important that you dilate the pupil once more. So it's not only pre-operatively, but after placing the ICL also, you may need to dilate the pupil once more to make sure that the flow of fluid from beneath the ICL is very smooth and a channel is created so that there is no disturbance of the iris at that point. So you can see that kind of a flow from beneath the ICL through the port should exist, and pupil dilatation is important for that. Now, this is another patient that is a very rare phenomenon, but I learnt about it after I went through such a complication. So this is Urey-Zavalia syndrome. Patient was normal on the first post-operative day. Regular patient, nothing abnormal in the procedure or in his refraction or in his eye. And then he comes back on the third day with severe pain and slight blurring of vision. And on looking, you can see that the IOP is raised, the cornea is hazy, and the pupil is atonic and looking like that. So now this I thought was a routine post-operative elevation of IOP, which is very, very rare, but I thought some visco might have got trapped somewhere. But this, even after the intraocular pressure was relieved, it took a very, very long time for the pupil to come back to normal. Even at 2 months, this is how his eye looked. And so this appears to be what we describe as Urey-Zavalia, usually following a keratoplasty, especially lamellar, after, you know, putting, inflating the chamber, after overinflation of the chamber in lamellar keratoplasty. So I suspect that was the reason why this patient presented in this manner. Now, the treatment is, of course, reduction of the intraocular pressure. I've used pilocarpine also to try to reduce the pupil, but there is some amount of ischemia that is always left behind. Now, now coming to this patient, now this was a patient post-trauma whose ICL had rotated. You can see that the markings where the re-rotation is attempted is very different from the way the ICL is oriented, approximately 30 diopters away. So that's very important. For each dioptric turn, for each degree of rotation, there is a 3.3% loss of dioptric power, especially in a high astigmatic ICL, and that's very important. So if the lens is rotated by more than 10 degrees, then that's 33% loss of power. So it's very important that the lens be rotated back, and that is done by gently lifting one haptic at a time and tucking it in, because the haptics are in close proximity to the zonules and we don't want to damage the zonules. So once the lens comes back to its position, then we can exit. So a high volt and a low volt are equally bad. Now, high volt would lead to narrowing of the angle, pigment dispersion, and high chances of glaucoma. Some people have even considered endothelial cell loss or attrition to be higher in such high voltage patients, where the normal range is around 2 to 10%. That's usually just after surgery. So in such a patient, sometimes explantation of the ICL is what is important. So because the ICL is very pliable and it's made of a material that can be easily manipulated out of the anterior chamber without damage to adjuvant structures, that is the procedure. It can easily come out through a 3.2 incision, folded just like it was passed in. And sometimes if you find that's difficult, you can slightly increase the size of the incision, use the same instrument to hold the ICL. Now, cataract may happen in any patient either spontaneously or with a low vault. Now, this was a high myope who had cataract following trauma. And here the ICL implantation was done, the IOL implantation was done after keeping the ICL in the anterior chamber above the iris. So you can see that Rexis is being done under the ICL. Now the need for this was that he wanted a multifocal intraocular lens, a 35-year-old patient, and he was very used to good near vision, and he wanted to retain that. And I could not find a multifocal lens in that dioptric power had I removed the ICL, so I needed to keep the ICL in. And you can see the cataract is very soft, the patient being young. The most important thing is to protect the ICL with viscoelastic. High density viscoelastic is preferable, and the ICL, the IOL, once it's inserted inside and aligned well, the interface needs to be washed really well. Now this is also true when you're going to use an ICL as a piggyback lens in a patient with an intraocular lens and a high refractive residual error. So the interface needs to be washed so that there's no biofilm or bioresidue formed at the interface, and the patient does well with good vision. So I've done other cataracts also. Even after removing the ICL, femtosecond can also be done via the ICL. Now retinal detachment, this is another patient following trauma with ICL who developed a retinal detachment. So it was decided to retain the ICL, and you can see that the surgery is being done under the ICL. So visualization is very good, and you just need to be careful that you don't increase the intraocular pressure too much when you're doing scleral buckling to prevent signs of anterior segment ischemia. So these are some of the complications that you may need to deal with while handling phakic intraocular lenses. Thank you very much.
The very nice videos. I just had a couple of queries. One was regarding the vertical vault, Swapna. So if in spherical ICLs, it may be a good idea to try and see if you can put it oblique or vertical before exchanging it.
Yeah, because we know that, unlike the horizontal and vertical obvious diameters of the cornea that we see, sometimes the diameter along which you have placed the ICL may not be the maximum. And if you reorient it in any particular manner, then it may, get very smoothly tucked in. But that may not be a possibility with a toric ICL, as in
spherical. This is why I said spherical. Second was, I think, explantation of some of these phakic lenses is a challenge, especially the ones that are made of acrylic. So if you're looking at IOCare and the biotech, the Appaswamy ones, I think trying to take it out through the same incision that you put it in would be a challenge. I think most times you would need to increase it to 4.5.
Yes,
compared to the star ICL, which is a lot more.
Very true, because the ICLs are much more thicker with, the phakic IOLs with the Indian manufacturers I've found to be much more thicker and slightly less pliable than the Collamer lenses.
And last was, I think we had this discussion because I also have a patient post ICL cataract, which we did. One was that was a lovely video, but how did you do the calculation for the multifocal?
Yeah, I think that's a very relevant question, and the question that should be asked here. It's because I was the primary surgeon, so I knew what his refractive error was, and that is the target I put for calculation of the IOL. So normally when we calculate an IOL, we put the target as plano or 0. And then we take the IOL in a patient that we do cataract in. But in this patient, because I was retaining the ICL, I put the target as -12 diopters. which was the original refractive error of this patient, and then calculated the IOL, and that is how the lens power was determined.
So you basically, on the IOL printout, you go higher and higher on the expected residual refractive error.
Yeah, but you know IOL printout will give you -12, so you need to factor in the target as -12. So that your mean IOL power, the thing that is highlighted in your IOL box, that will give you a residual of -12. Yes.
For such cases, the ray tracing technology helps you in IOL power calculation. So you should use all the ray tracing technologies. So that will nullify that part.
Mm-hmm.
So like, use the oculics or Phakic will be useful for that kind of cases, particularly for IOL power calculation. Very nice presentation, ma'am. I would like to ask, which are the criteria for the explantation in high volt? All the high volt you will try to expand, or the IOP rise or anything, any other?
Yeah. Very, very relevant question, because IOL vaults as high as 1.5 times the corneal thickness may need not be explanted, provided the anterior chamber depth is very good. Now, when you start seeing that the angle is very shallow, there is a lot of pigment dispersion, the chances of peripheral anterior synaptic formation are high, are when you would require to explant the IOL, and if the AC depth is borderline, and you have put in an IOL according to calculations, but still you find that the angle is very shallow and you need to go one step lower. Such are the situations when you need to explant the IOL. Now, before you actually go into a full-fledged glaucoma, these would be the preliminary times when you need an explantation. Any other suggestions?
No. Ambarish, anything you'd like to add? Okay. In the meantime, Dr. Pratmesh or Sri Lakshmi?
No, Sri Lakshmi.
Madam, my question is just on the ICL rotation. I have a patient after the ICL, who has a astigmatism of -1.5, and still there is a residual. On checking on the rotation, I find it is just about 5 to 7 degrees of rotation. So what should be the plan? Like, should we go back to the original axis which was calculated that the ICL axis should be at this level, or is there any formula to neutralize that astigmatism?
Yeah, so my question here is, was that patient a purely astigmatic patient?
Yeah, he had astigmatism.
Yeah. So I have also burnt my fingers that way, because there it is very, very important that you don't even have 1 to 2 degree of rotation. It's especially because it's pure astigmatic, so it's very important. So in such a patient where that rotation is happened, the best and the longest term treatment will be to just go in and flip it back to the original position.
Original only?
Yeah.
There is
that would be fine.
Calculation.com or anything that you can go to some...
Yeah, I know. That can be done for IOLs basically, where you can, do, that tells you how much to rotate, whether you need rotation or, But another option is, if you had actually done the patient, but for 1.5, I don't think this would hold. You had not done a laser vision correction because of some, topographic indications, I assume. So top-up laser is also not an option. So I recommend that you go in and put the ICL back in the correct position.
But this patient I am facing a problem. I did one time that I put the ICL in the axis which was required there, but again patient has a rotation. So why it is occurring, and why the rotation has reoccurred?
Or the vault, what would be the vault of the patient?
The vault is normal vault in this patient.
Because,
No, I think what, sir, what your question is that why is it going out of the astigmatic?
Because he is asking again, doctor, if you put it again on the axis, can it rotate again?
Yes, because the one reason for rotation is, one is eye rubbing, which would probably a more common, right? The other is the undersizing. So if you go to the higher, if you want to go in again, I would prefer you increase the size by maybe 0.5, 0.25 if you have that depth available, and then put the same power on the axis, and then see the chance of rotation are going to be less. A simple option maybe is to just try and do a laser vision correction, just for that one. That would be the simplest.
No, but I am sure that the laser vision correction was not done in the first place for 1.5 because.
But now we have to do only for 1.75 cylindrical power.
5, 6 maybe. The residual power.
It's just a